first in-person meeting since COVID, so you will have to excuse any oddness that comes from me. I'm not used to being with people these days, but I am thankful that you have had me here today. So I have been with Medicaid actually for 7 years, and so this is sort of a dump of my brain into one slide presentation. So this is 7 years worth of knowledge that I've obtained throughout the last several years, and we are going to move a little bit fast today, but I am hopeful that we will have about 15 to 10 minutes of question time after the slide presentation. You should also consider this slide deck actually as a desk aid. So there's actually a lot of information in here that we're not going to cover in detail today, but please feel free to use it just, during your course of everyday activity. So with that, we'll get started. Hopefully. Thank you. So this is the agenda that we're hoping to cover today. As I said, there are a number of slides that we won't cover in detail, but please note that we do have several slides worth of definitions that we use frequently at Medicaid and at DODD. They will be referenced throughout the presentation today, so that is there for your use at your convenience. We will cover the SSA survey that ODM actually undertook in the summer of just this past couple months. And so we will talk a little bit about that and what we've learned from that experience. And then we'll really dive into Medicaid basics, including state plan services, managed care, medical necessity, Healthchek, all kinds of really great topics. And then we'll get into some of how those topics interact with the waivers, which you are all familiar with. And then again, we'll have time for questions at the very end. Thank you. So we're going to just go through the next couple slides fairly quickly. Again, these are the definition slides. We're not going to spend a ton of time on these, but I do want to point out a couple items. Next slide, please. Thanks. So you will note here that we define managed care organizations as MCOs. You may also see that throughout the presentation as MCE or managed care entity. And we're going to talk a little bit about the future of managed care in Ohio. So we will touch on that a little bit, but I did want to let you know that MCO and MCE for the purposes of this conversation can be used interchangeably today. Next slide, please. And then again, just some other definitions that we use frequently: nursing facility level of care, waivers, ODA, that sort of good stuff. So that is all there for your reference. Okay. Now we're going to get into the County Board and SSA surveys that Medicaid recently completed. That survey actually took place over the course of the summer months. And so I think that was actually in July or August of this year. So we wanted to thank you. Next slide, please. Thank you for anybody who participated in that. Thank you to your supervisors who may have voluntold you to participate. We really appreciate the feedback, and we heard a lot of initial concern that this was really a test of your knowledge. It wasn't. This was really a test for us to understand how we can do better for you. So with that, I do have a snapshot of survey results on the next slide. Really, this was an opportunity to really improve communication between ODM and the county boards. We know that you're in constant communication with the department, and we really want to improve that on the Medicaid side as well. So we really learned what was important to you and what you found valuable in terms of communication strategies. We heard pretty clearly that Memo Mondays, as an example, is a format that DODD uses, and that you would like us to consider using that from Medicaid too. So that is something that we've taken back to talk to our communications team about. Other suggestions as far as topics that you would like to know more about included EVV, managed care, EPSDT. Those two latter topics are actually things that we're going to talk about today, so hopefully that helps clarify some of the questions that you may have had. Also, just more assistance with the topics above, so not just communication, but really trying to understand those programs. With that, we want to take an opportunity to talk a little bit about how we intend to improve our assistance to county boards. Yeah, and my clicker is not totally working. We're now working, thank you. So how do we intend on doing that? Well, we've actually done some collaborative training efforts with the department over the last year. And that may have been missed because of COVID, right? We were in the height of COVID last summer, and that was probably not the best time to unroll some of that. But I did want to remind folks that there is a Medicaid state plan training that is on the department's website. It will look similar to what we'll cover today, but you can actually earn credit. I believe it's CPD credits if you take that course on the DD website. Again, I'm here today to help and assist with questions regarding managed care state plan services and how those interact with our waiver services. So this is really kind of our first initial step into trying to improve our communications with the county boards, as well as tailored ODM communications. We've actually improved the Medicaid website pretty significantly over the last year or so. And so this website is actually going to allow you to choose topics that may be of interest to you that you can sign up and receive constant communications about. That's something new that seems really, really basic, but we just didn't have that ability until relatively recently. So I would encourage you to look at that. But again, results are really helping to inform different areas across the Medicaid program about how we can do better for you. And so again, I really do want to thank you for participating if you did participate. And I think that this was beneficial not just for Medicaid, but for OACB as well. I think we have a fuller picture of the number of SSAs in the state, and that will certainly help improve OACBD's work with you as well. Okay, so now the bulk of today's presentation, Medicaid state plan kind of basics. We're first going to talk a little bit about coverable Medicaid services and really how those services are covered. I'm a little bit of a policy wonk, so Lisa asked that I kind of put this into more simpler terms that an SSA would find value in. So I'm not going to get too technical in terms of federal regulations and things like that, but I do want to make sure that we have an understanding of what the Medicaid state plan is. Each state actually has their own state plan. So, across the 50 states, services that are covered are going to look a little bit different. So what you see in Ohio might look different if you were in Pennsylvania, as an example. But you can think of a state plan as sort of the contract between the state and the federal government about how they run their Medicaid program. Our waiver programs are actually not part of the state plan, so those are separate and they run through a separate kind of authority. But we certainly interact with the state plan, right? Our individuals receive state plan services, and they do so through the Medicaid state plan. What you see on your screen is actually a list of coverable services. On this slide are services that Ohio Medicaid fully covers. Again, that might look a little bit different depending on what state you're in, but there are some limitations to these services, and we'll talk a little bit about that as we move forward with this presentation. So how are state plan services covered? There are a number of different mechanisms. Most typically in Ohio, what you'll see is they are covered through an MCO or a managed care organization. As of 2017, we have allowed our recipients who are enrolled on a DoDD waiver to enroll on an MCO as well. We have approximately 5,000 individuals who are actually duly enrolled in that way. Especially in our smaller counties, you may not have a lot of people who are enrolled with a managed care organization, so that might be a little bit more kind of unfamiliar to you. But our larger counties certainly have quite a number of people are actually enrolled on both the waiver program as well as an MCO. So the MCOs are actually responsible for not only coverage, but payment of services when they're enrolled in an MCO. And MCOs are required to cover all medically necessary Medicaid services. That exception is actually targeted case management, or TCM, as you guys know. TCM is only provided by our county boards, and it's paid for on what we call a fee-for-service basis, so our MCOs actually don't cover that. This is just a picture of the landscape in Ohio today for our MCOs. You will see, I think it's on your left, the traditional Medicaid managed care plans, and then you'll see the MyCare Ohio plans. It's important to note that these plans are actually going to be changing a little bit over the next several months. So starting in July of next year, you will see different managed care plans in play. Some of them will be the same, but we do have some different ones. This is all part of the procurement effort and the kind of the new state of managed care. So this slide is really just the managed care mission statement. And we're really trying to envision the way, or re-envision the way that people receive services through their MCOs. The mission behind our next generation of managed care is really to focus on the individual rather than the business of managed care. A lot of people think of managed care as a business, and it certainly is, but we're really attempting to reshape that focus so it's more about the individual rather than the MCO. And we really want to do better for the people we serve. This is just kind of a highlight of the next generation of managed care, and you certainly don't need to know all these details, but we did want to provide you with an overview of what this will look like in the not too distant future. Really, the biggest kind of pieces that you'll want to draw attention to are that managed care procurement. So again, our MCOs will look a little bit different in the next several months. and of course, Ohio RISE. We won't touch on Ohio RISE a lot during today's presentation, but I'm happy to take any questions that you might have about it. Ohio RISE is part of this new generation of managed care, and it will actually be a managed care program. So let's talk a little bit about the differences between fee-for-service and managed care. One of the biggest reasons somebody might choose an MCO versus traditional fee-for-service, if they have that option, is the MCO's ability to find providers, specifically those for state plan services. We find that it's really helpful, especially in rural areas. The plans hold that responsibility for ensuring that state plan services are covered, that they have access to those services. So really, that's a huge draw, and it takes some of the lift off of your shoulders, if you will. So if you have a family whose child might be enrolled in managed care and they might need some assistance with locating a home health aid provider, you can refer them to the MCO to say, hey, MCO, this is your responsibility, and we can work together to ensure that that happens, but the responsibility really lies on that MCO. So that's a huge benefit. We do have what we call a grievance process. So people do have due process and hearing rights and all that sort of thing for coverage with managed cares. We wanted to highlight a little bit about the differences between responsibilities of the MCOs and of course the SSAs. Again, really, when I talk to families, I try to encourage them to think about the managed care option, again, just because of the access to providers that they have and the responsibility for coverage. So we really do think that this is an important tool in your tool belt to assist families with some of that communication. To that end, we actually have a communication protocol, and we've heard through our SSA survey results that not all of you are very familiar with this. So I want to talk a little bit about that today. And I actually sent over a copy of that communication protocol to OACB, so we can certainly get you access to that if you are interested in that. But really, this is just kind of an outline of expectations for the MCOs and how you can help assist with communications between the plans, between parents, family members, individuals, and this really kind of lays out what our expectations are as far as communication between all kind of entities that are in play for an individual. So hopefully this is a helpful tool for you. Again, if you don't have it, let us know. We can certainly get you a copy. Really, all this to say in a very kind of rushed fashion is, MCOs, the SSAs, counties, really need to help work together so that individuals' needs are being met. You can sort of think of the MCOs as handling more of the acute care side of the individual's needs, and you're really helping with that habilitative and long-term care need. So together and collaboratively through that effort, we're looking at the individual as a whole. And so, that communication is really key to ensure that that individual's whole self is being provided for. So we're going to talk a little bit about medical necessity, and I know that this has been kind of a hot topic in county board world today, so I'm hopeful that I can answer any questions that you may have. Medical necessity is actually defined in Ohio Administrative Code. There are two types of definitions, one for individuals 21 and over, and that's what you're seeing on your screen right now, and one for individuals who are younger than 21, and that's going to be the next slide here. I want to pause just to give people a moment to take a look at this. And we're going to flip to the under 21 definition. I think it's really important to think about medical necessity as far as these slides are defining them, and as far as the Ohio Administrative Code is defining them, is really applying to the Medicaid program as a whole. And so you think about Medicaid, we think about the kind of medical services that someone would need: hospital coverage, nurse coverage, dental coverage. And so medical necessity in the kind of broad Medicaid terms is going to look a little bit different than it would be for a waiver, for instance. Waiver services are really, in some ways, not all that medical, right? Think about adult day supports, think about vocational habilitation. How would we define medical necessity for something like that? It's really meant to be able to keep the person at home and safe and interacting with their community as much as possible. So while these definitions certainly would apply to waiver services, I'd like to think of it as a little bit broader for our waiver folks and our waiver services. And again, I like to think of kind of medical necessity in terms of waiver services being able to keep that individual safe outside of a facility, in their community and thinking about how we can do that and achieve that. The next topic is EPSDT. You will also hear this referred to as Healthchek in Ohio. That's sort of the Ohio branding because we brand everything at the state level. But really EPSDT is just kind of a benefit of Medicaid that you will see across states. It's a federal requirement. Really what this means is kids' needs are met through medically necessary services. We often think of Healthchek as just applying to home health services or private duty nursing services. Healthchek is really broader than that. It's about screening, vision, dental, hearing, and diagnostic services that a child might need. Can certainly include those increased home health hours or increased PDN hours, but it's really broader in terms of trying to understand just diagnostically what's happening with a child. These are some details on EPSDT. Again, it's Healthchek in Ohio. This is certainly not a limited list of services that Healthchek would cover, but it is certainly inclusive of this list. Again, inpatient, outpatient hospital stays, lab, x-rays, the home health is on there, as well as the following. So again, dental services, diagnostic tests, respiratory care services, things of that nature. So really think about anything that Medicaid covers, a kid would have access to, potentially could have access to in additional hours or authorization than maybe an adult would have access to. And would also cover things that Ohio Medicaid doesn't typically cover. So again, think about our discussion about state plan, our state plan contract with our federal partners, right? Our state plan dictates certain things that Ohio Medicaid covers. We typically cover quite a bit in comparison to other states. But if a child needed something that Ohio Medicaid doesn't typically cover, federally, we have an obligation to cover it for that child as well. So there are things that Ohio Medicaid may not actually cover in practice, but we might for certain situations for a specific child. Just some reminders, again, it's open to, EPSDT is open to anybody who's under the age of 21. They must be enrolled on Medicaid. There's not a separate application for Healthchek or EPSDT services. It's just a benefit that's offered to individuals enrolled on the program. Medicaid providers typically understand how to submit paperwork for authorization and things like that. It typically will happen through a physician's office. And really, again, just EPSDT is there to ensure that a child's needs is being met as long as it's medically necessary. I did want to, before we move too far from the topic of Healthchek, cover the myth of 54 Healthchek hours. We have heard this in passing over the years, that there is a limit of Healthchek hours, that limit being 54 hours per week for a child. There's actually no such limit in Ohio Administrative Code rules, policy, and you won't find it. So we have some limitations in rule, but again, that might be exceeded for both children and adults in certain situations, unless it's specifically authorized by a physician that a child or an adult would receive 54 hours. There is actually no limit as far as Healthchek hours for a child. We're going to be covering a little bit more in detail about state plan services. As a reminder, anybody who's enrolled on a home and community-based service waiver, like IO Level 1 Self, they will have access to all of the state's state plan services, in addition to the waiver services. We're going to be discussing home health and PDN first. This is a very, very large topic. And again, this has been kind of a evolution, if you will, in terms of the policy, in terms of the program, in terms of how we're talking about it with counties specifically. I will tell you that we have some staffing changes happening at Medicaid right now. So the woman who was previously responsible for PDN and home health actually just retired yesterday. So questions are going to be sent to the section that I work for, and that information we'll cover at the end of the presentation. But right now we don't have a point person for any of this information, so I will certainly do my best at the end of the presentation to cover questions related to this topic. As part of the home health benefit, we have something called a registered nurse assessment, as well as consultation services. You can think of these as sort of the preliminary to a home health service being provided to an individual. It's really a face-to-face or telephone contact to really understand an individual and what they might need through the home health benefit. There are a number of different ways that RN assessments as well as consultation services shall be used. And I'm gonna just go through these slides a little bit quickly, but they are here for your desk use. Really what I wanted to get into is the home health nursing services, and we'll discuss home health aid services here in a minute. Home health nursing services are different than our private duty nursing service in that they're really supposed to be intermittent, a little bit more time limited, and would not cover anything that a facility would be responsible for. So for instance, if somebody's in an ICF-IID, that would not, an individual in an ICF-IID would not actually be eligible for home health nursing because that is the responsibility of the facility. Home health across the board actually can only be provided by a Medicare certified home health agency or an MCHHA, and those must be ordered by a qualifying treating physician. There are some specifics about what would be required as far as an authorization. So a provider would actually have to submit something called the Certificate of Medical Necessity. It's an ODM form. You can find it on our website. And then the individual's plan of care. So in this case, the ISP would have to include documentation about that authorization as well. That authorization, again, just comes from the physician, and it's really the responsibility of the provider to make sure that's in place. There are some home health nursing limitations. You will see that on the screen. And again, it's really important to remember that home health nursing is distinct from PDN. PDN is supposed to be a little bit longer term, longer hours. And this is really just an intermittent benefit that would be available to anybody enrolled on Medicaid. Home health aid services, you can think of as sort of like a personal care type of service. We don't have true personal care that's available under our state plan today. The closest equivalent is our home health aid service. Again, this can only be provided by a Medicare certified home health agency.
Is it Medicare certified?
It's Medicare certified. Yeah.
Is that another ballgame?
It's a whole nother ballgame. I will not go there. I don't pretend to understand that, but yes, it is. That is correct. So the slide is reading correctly. It is Medicare, not Medicaid certified. The same requirements regarding inclusion of home health aid as far as being incorporated into the ISP applies here, and as do some of the kind of frequency and face-to-face requirements by a treating physician. Now, this is my favorite topic, as I'm sure it is everybody else's, private duty nursing. I say that a little bit facetiously, but private duty nursing is used a lot by our individuals enrolled on waiver programs, not just those on a DODD waiver. We see that a lot in our nursing facility level of care waivers as well, like Ohio Home Care. Again, really anybody enrolled on Medicaid can receive PDN services so long as they're medically necessary. And you'll see the difference between the hours that are available to somebody throughout a week. Again, this is much longer in term, higher frequency during the day. There's also a post-hospital benefit for PDN as well. Again, anybody enrolled on Medicaid who's being discharged from a hospital might need some nursing care, has available to them up to 60 consecutive days of PDN post-hospital as well. It's important to note that PDN is not for the maintenance or provision of just maintenance care. And this will look a little bit different from our other waiver programs in Ohio. PDN authorizations, as you all know, run through our county boards. You work with DODD on submitting those. A nursing task inventory is actually required as part of that authorization. And this is a separate process from many of our other waiver programs in Ohio. Typically, we don't have kind of our case management entity involved in authorizations in this way. So this is a little bit unique. Again, there are some limitations on home health and PDN hours, and you will see that on the screen, but it's really only a limitation as far as the number of hours that are authorized by that provider themselves, and potentially the county board regarding PDN. Again, important to note that kids through EPSDT might have some additional available hours, may extend beyond the limitations that you'll see in the OAC just because of that EPSDT benefit. And providers really must ensure that home health services are on the ISP. So you'll be in pretty frequent contact with some of those providers if you're familiar with that process. Some additional tips to remember, again, DD is the authorizing entity for PDN. And if you have an individual who is served on an MCO, that authorization for PDN or for home health actually works through the MCO and not through the county boards. The home health benefit, again, kind of federally speaking, also covers medical supplies, equipment, and appliances. If you're familiar with our Ohio Administrative Code rules, home health and PDN are covered in 5160, Chapter 12. You will find our medical supplies, equipment, and appliances in a different chapter of those rules. So sometimes it's a little bit confusing about where you need to look, but I'm happy to kind of field some of that if needed, either through email after this session today or throughout the session. But again, DME supplies are actually covered as part of the home health benefit through Medicaid. As are PT, OT, speech, and audiology. Again, some of the rules and some of the services will have some specific limitations to them. It's important to remember that they may be exceeded for a child who is in need of those services. Okay. I know this is a lot. How are we doing? Okay. 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 Yeah, that's how I feel every day. So we're going to move into behavioral health covered through Medicaid. So this is going to be separate from your home health benefit. Behavioral health services, I'm sure, as you know, is a hot topic in Ohio today, mostly because of the work around Ohio Rise. Behavioral health actually went under a redesign, I want to say in 2016. So if you've been in the system a long time, you will note that this is significantly different than it looked like maybe 10 years ago. Really, behavioral health is just a term referring to mental illness and substance use disorders. And Ohio Rise will significantly impact what's available to a child specifically once that program goes live in July of 2022. Again, we're not going to cover Ohio Rise in detail today, but if you do have questions, I'm happy to take those. These are some of the services that are covered through the Medicaid mental health benefit. I hope you can see that. Okay, and we're not going to spend a ton of time, but I did want to make sure that you kind of had a landscape of what was available to individuals enrolled on Medicaid today. There are some specific services that are only available for youth enrolled on Medicaid, and there is one service specific to an adult. So somebody, I think it's 18 in the Medicaid world, somebody over 18 would have access to that adult service. This is, again, just a snapshot of substance use disorder benefits through Medicaid. And we'll talk a little bit about ABA. I know ABA has been, again, kind of a hot topic with some of our county boards. ABA is actually provided most traditionally through an MCO, although it can be provided fee for service if a child doesn't have an MCO. It's much easier if the child is enrolled with a plan, though. ABA is a therapy that's used for specific behaviors and will work on social skills, communication, that sort of thing. We are actually working on a full ABA policy as it relates to both fee-for-service and MCO coverage. Right now, there's actually not an Ohio Administrative Code rule governing ABA and its provisioning. Those are handled on a case-by-case basis, but the MCOs are required to cover ABA. So again, if you are working with a parent whose child might be enrolled on a plan, ABA is something that the plan should be providing so long as they're finding it medically necessary for that child. We're going to move into important reminders for individuals. We'll take questions at the end. Yeah, thank you. So important reminders for individuals served on our waiver programs. Again, keep in mind that waiver services are not part of a state plan, but somebody who is enrolled on a waiver does have access to those state plan services. The HCPS waiver programs are actually optional for a state to provide. So you will find that the ICF-IID facilities are actually the entitlement, and that at the option of the state, we are providing waiver services to folks. So it's just kind of important to know that. Some people, again, as we've talked about throughout the entirety of this presentation, might be served through an MCO, and there are certain limitations to services on the state plan services. We're going to talk a little bit about service sequencing. State plan services really should be used primarily before tapping into waiver services, especially for like state plan services. So as an example to this, think about PDN. PDN should be accessed first prior to somebody accessing the IO waiver nursing service as an example. In most cases, the DoDD administered waivers are the payer of last resort for Medicaid covered services. And as you can see here, really, again, just a very basic visualization. The state plan services are first, waiver services should usually come second. So you might be asking yourself, okay, well, how do I know when to submit something for state plan consideration versus a waiver service? Should I just authorize it under the waiver? Again, generally, state plan services should be looked to first as a funding source. And because of the way items are actually covered through our durable medical equipment benefit, it's important to submit a prior authorization for waiver service coverage to the Department of Medicaid first, where applicable. And again, we don't have to get into the details about why DME is so complicated, because it is. But generally speaking, the rule of thumb is if there's a potential for a service to be covered through state plan, as an example, really that request for a prior authorization should be submitted to Medicaid first. If the prior authorization is denied for typically medical necessity hasn't been met, then certainly we should be looking to the waiver to cover that. And I do have an example on our next slide about a situation like this. So usually we'll see this with PDGs under self. Hopefully, this will no longer be an issue come July when we enroll PDGs in our level 1 waiver as well. I think we've done a lot of work over the last couple months in terms of guidance, in terms of cleaning up the PDGs rules. So hopefully we'll see less and less of this. But I did want to just provide this as an example. So CMS does require certain items to be on the ISP when we authorize PDGs. Those items are listed below. So the goods and services purchased under PDGs would have to be clearly linked to an assessed need of the participant, and that assessed need should be on the service plan. And then specific goods and services that are purchased under PDGs should actually be on the plan as well. So it's not just we're authorizing PDGs, it's what did you purchase using PDGs funds. So just as an example, we included a scenario that somebody might encounter for an individual enrolled on the self waiver today. So let's say you have an individual with some trunk control issues, the assessment from the physician that you've obtained, but also through communication with the family and with the child, indicates a greater need for physical activity, social interactions with peers, and just kind of greater community integration. And so you decide that PDGs would actually be appropriate to purchase an adaptive swing. There are certain situations that Medicaid will cover adaptive swings, but it's not a 100% guarantee that Medicaid will cover. Again, DME is a little bit funky in that way. So if somebody were to receive a denial from Medicaid saying that that adaptive swing isn't medically necessary for that individual. Again, let's think about the medical necessity as it applies to our waiver programs. Does it meet somebody's assessed need? Is it keeping that child out of a facility? Is it promoting community integration? Is it helping with the trunk control? If those things are yeses, we should be looking to PDGs for that funding source. And we certainly would expect that that authorization would work through PDGs in that way. Again, it's just kind of, it's important to note that medical necessities should look a little bit different between our waiver programs and our Medicaid plan, state plan, and in sort of in conjunction with those OAC rules that we talked a little bit about earlier, but really expanding those OAC definitions to fit within our waiver programming. Okay, and I think I've left enough time for questions. So yes. I have included a list of resources and contacts at the Department of Medicaid. I actually work within our home and community-based services section, HCBS policy. You will see our email address here. Oh, I went too far. Can you go back to Yeah, here we go. So ODM Contacts. So you'll see the HCBS policy as an email address on this slide. You will also see a number of different areas within Medicaid as well that might be more appropriate to answer questions. Specifically, our clinical area, they work most closely with our MCOs, and so can certainly help with facilitation of communications between a county and an MCO where in play. So you'll see that at the top. I have included our MSY email address as well as on the next slide. I think it's the Ohio RISE contacts, or at least I hope. The Ohio RISE email address, if somebody needs that, I'd be happy to provide that. I've also included a list of online resources that might be helpful for you all as well. Draft rule notifications, more information about the next generation of Medicaid managed care, a Medicaid provider directory that specifically includes information about state plan providers, as well as our public notices you might be familiar with anytime we post a waiver amendment that actually has to go to CMS, and we require public feedback. And so that last resource there is the link where you will find those. And then this is our current list of MCO provider resources. Again, please feel free to use this or provide this to families that you're working with. We're also completely willing and able to help assist with communications between counties and the MCOs as well. And at that, I will take questions.
All right, good. We have a couple questions online too, but I'll grab, oh, there we go. Frank has got a question for us. I will bring it to you and I'm going to restate it, or you can talk into the mic.
You said that ABA is available as a planned service through the MCOs.
That is correct. Yeah.
So if somebody's on a level 1 waiver, they would qualify for ABA?
So long as it's medically necessary as determined by the MCO, that individual has access to ABA through their managed care plan.
Thank you.
You're welcome.
All right. You guys keep thinking up. All right. I'm going to grab one of the questions offline and I'll come right over to you then. All right. So if a person has a managed care plan, they want some clarification. Is TCM billing rejected? You had mentioned.
Yeah, so that's a great question. TCM billing should not be rejected if somebody is enrolled on an MCO. We've actually done a little bit more system work to make sure that that wasn't happening. So if a county is receiving denials of TCM claims for somebody who is enrolled on a managed care plan, please let us know and we'll definitely dig into that, although that should not be occurring at this point.
Thanks, Jackie.
So can you talk a little bit more about the definitions of medical necessity specifically related to PDGs? Because I think we've all been struggling with PDGs. Constantly getting our Medicaid denials for that adaptive swing. Medicaid saying it's not medically necessary, but in order to be covered under the waiver, it also has to be medically necessary. So that's right. That's confusing.
Yeah, that's a great question. So again, it sounds like, you know, you are service sequencing appropriately. So you're receiving that denial from Medicaid. Again, oftentimes we're seeing it because of medical necessity reasons. We do sometimes see a provider just not submitting their prior authorization correctly, so it will be denied for that reason. That's not a good enough reason. They need to resubmit it appropriately. But if it's for true medical necessity, that's something that we need to consider, but also we really need to be thinking about, again, those tenets of why somebody's on a waiver program to begin with. It's to be at home. It's the community integration, keeping them safe and out of a facility if that is their choice. And so in combination with those tenets, we need to determine if something is truly appropriate for an individual. So that adaptive swing, right? The example that I used was for somebody on self and it was for a child. If we were meeting those assessed needs for that child through that swing, again, the need for community integration, the need for socialization with their peers, that is something that we should be considering as part of that PDGs authorization. Now, I know that the department has received a lot of kind of questions about how PDGs functions, and I know that there's a great TA team now at DODD to help kind of troubleshoot that. So Nyoka, I don't know if you have any other thoughts that you want to add to that.
Yes, I did want to just add that there, I'm not sure how recently you've submitted a PDGs request, but we have been making some changes to how we're thinking about that. And so we are trying to look at things a little bit differently in the sense of just processing them. So not immediately denying a request because Medicaid denied it, and looking at waivers a little bit differently. And then also just trying to look at the assessed need a little bit differently versus medical necessity. So we are definitely looking at our process a little bit differently. We do still have the same rule. So we are bound by the same rule until we get the new rule changed, but we are trying to work with the counties as those come in to really try to process them a little bit differently. So certainly if you're continuing to have issues, let me know and we'll work on that. But it is our goal to try to get those processed based on assessed need.
So I need to restate his comment because people can't hear on Zoom, but he said, we don't always know that we have issues until 4 years later. So, yeah, you want to say anything else?
Well, and when we get back with counties, that's one of the things we're trying to talk with them about is how we might word the ISP differently, what kind of assessment we might have to strengthen the county board's stance on this. So I'm really trying, and we're trying to build a TA team that's really going to work with counties. So I don't know how many of you have had a PDGS request recently, but we are really trying to make it a process that's helping you and have a better experience on the audit side as well. So that is our goal. Yes.
Yeah, and just to jump on that, OACB has been meeting with a lot of counties, with some representatives about PDGS, and we've been in constant communication with DODD's MDA program and Jackie. That was one of the reasons, and looking at how to change the rule. And it really, all I can say is it does deserve a new, fresh look at what makes sense. And what if a county feels like something would support somebody and it has some kind of, meets those criteria that Jackie was talking about, then let's have a conversation about it. Like, don't go by what happened before. So, all right, we got one right here.
Mine is pretty quick. I'm pretty sure I speak for many SSAs when I talk about the frustration of specifically home health care services and identifying an agency that will provide them willingly or unwillingly, be it as it may. And I know you mentioned calling the MCO and putting the responsibility at their feet, which I absolutely love that idea. What happens when I call them and they say, "Oh, we don't have, can't find them"?
Yeah.
Who do we pass our frustration on to at that point?
Sure.
That maybe could make a difference. I'm not sure what the reimbursement rate is. I'm not sure if those limited time periods are still an issue, because a lot of times people will say, well, I'm not going to drive out there for I can't get anybody to drive out there for 2 hours and, whatnot. So.
Yeah, no, that's a great question. And I don't need to tell any of you that the provider crisis is very, very real in all areas of the Medicaid program, not just the DD stuff. But I will tell you, so if you're running into roadblocks, especially with the MCOs, please get in touch with our care management team. That email is actually in the slides. Feel free to loop in HCBS policy as well, and we can kind of troubleshoot through some of that. Now, if there truly is no provider, I don't have a great answer for that, but we certainly are able to engage with the MCOs just on a little bit of a different level, and so we might be able to help through that kind of a venue. So I would encourage you to look through, to look to Medicaid to help facilitate those communications.
Yeah, and there is quite a few questions online about, in general, the shortage of nurses, the shortage of home health aides, all that. And again, limited time today. I mean, we're having it in our DODD providers. We're having it in the hospitals. If any of you, I know some people that have been turned away from hospitals because they have no more beds, right? We're not going to solve that one today. We're going to solve what we can answer. So I'll be right with you.
But I will say on that note, though, again, if you're having trouble communicating with an MCO about this issue, please reach out to us, and we will do what we can to help try to support that as much as possible.
Thanks, Jackie. This question was, how do we know if someone is receiving managed care as part of the waiver Medicaid, aside from whether they have the enrollment, if they don't have the enrollment card? Like
Yeah, so actually it should be on, that's a really good question. Let me take that back because I just want to double check my response. Can we note that?
Yeah.
And I will provide a response to that, that questioner through our mailbox. So I do want to double check on specifics though.
All right, I know there was an in-person one. There we go. Got to run to you. I'm Lori. I'm channeling my Lori.
I had reached out to the department about 6 years ago about Medicaid buy-in for workers with disabilities ending at age 65, even though the federal retirement age was 67. Because what had happened was somebody who was enrolled on a waiver in our county, a level 1, she turned 65 and her patient liability went from $33 a month to $636. I was told at the time that the directors of both Department of Medicaid and Department of DODD were aware of the issue and were working on it. I ask every couple of years because nothing's changed. So just thought I'd ask again.
No, that's a great question. Christine Brown might be able to answer that better than I can.
I was going to say, you answer, Jackie, and I'll give it to Christine.
But actually, so anything like case specific like that, we're happy to take a look into just to make sure that it looks correct. I think from a policy perspective, we are kind of engaged with Christine, with some other stakeholders about that policy change and that recommendation to increase the age limit. I don't have any other additional specifics around that policy consideration, but again, any case specifics, I'm happy to take that back and take a look for you.
I can share with you that under research, and I have data today with me, that the Department of Medicaid, as of now, when we are under this public health emergency, anyone who turns 65 during the pandemic is at this 65 plus freeze group when people are, while we're in this pandemic. And then once the pandemic ends, they have to decide between work or keeping their waiver Medicaid. I made this letter to the governor and I had this stuffed in folder, and a friend of mine, Nathan Turner, saw the governor just earlier today. Data shows that there is 420 65 and older. In the next 10 years, there's over 400 people a year, 419, that are having to quit working. And the thing is, I said the very specific thing about the age is 60. What about the retirement age going to 67? Because when we had created it, it was 65. I highlighted it and I put these words in red, underline, and made it yellow. There are 17 other states that have removed this age limit. And so are you wanting people to work, and do you want to collect taxes in Ohio or do you not? And the thing is, we are working on I have a number of legislators that I'm working with trying to create legislation. And I had a consultant that worked with CMS, and we're trying to work on creating this legislation. So when we get more info, we'll send it out. But the big thing is, and I don't kid you on this, and Lisa knows what I'm about to say, I have had talk from an individual where their SSA, she got a job in a county. She says she can only work 20 hours a week in order to stay on her Medicaid and her waiver. And I said, did your SSA even mention Medicaid buy-in? No, what is it? So that shows we have to get the forefront and really try to re-educate, because when it got changed in 2007, when DD Council created it, Ohio wasn't the first state that created MBI. It took about 3 years to get that created. So we're just going to continue until this gets done, but it's going to It's just like almost saying we're going to have to go on strike in the State House to say, oh, do you want people to work and paying taxes? And I did say this, the entire country, not just the DD provider industry, the entire economy is suffering. Why can't you, with having this age cutoff, you're making the economy worse. So if you want to talk with me, I can explain more.
Yes, she will. That's a very passionate discussion from Christine and from a lot of people. I think there's a lot of good momentum and we need workers right now, right? Like what a better time to tell people that we need to change that for everybody. So, okay, let's see what other question we got over here and how we doing on time. When supplies for home health services are not being fully covered per the recommendation of a doctor, can a prior auth be submitted to cover additional supplies?
Yeah, that should be submitted to us. If you're running into issues with that, please submit some information to the HCBS policy box. That email is in the slide deck, and we're happy to troubleshoot that for you.
Yay. People said they can hear us. Christine, they heard you really well, I think. What's the best way for someone on a home community-based waiver that is on managed care to go to straight traditional Medicaid?
They can actually just call the consumer hotline. So either the individual, their guardian, authorized rep, and that change can happen fairly quickly.
I think we got any other questions in here. We just have a few minutes. I feel like a lot of them are about the shortages, which with ODM requiring ICF staff to receive the COVID-19 vaccination to receive Medicaid dollars, will this carry other PDN, SPN providers that accept Medicaid waiver dollars?
Yeah, I actually don't have any additional information at this point in time regarding the federal requirements around vaccinations. I imagine that Medicaid will be rolling out an official and formal communication about that topic as we learn more. I believe we actually submitted some questions back to CMS on those requirements. So that's still pending with them. And again, be on the lookout for some formal communication.
And if you want to hear some passion about it, just like you heard Christine, go talk to Lori Stanfa about that. So she's got some ideas of her own, I think. All right. Any other questions? I think we caught most of them and we are 2 minutes ahead of time. Oh, we got one. There we go. Last one. My son would be so proud for running. I'm jogging.
Hi, I was just wondering if when the new rules come out, if anything's going to be addressed with Ohio home care waivers. Any new, I've run into where they would reject someone applying for them simply because they have a disability. And that, that's really been an issue for some families. So I didn't know if there's going to be any clarification on those rules when the new rules do roll out.
Yeah, that's a great question. I don't know if it's a 2-minute response, but I will try. So we are actively working with the Department of Developmental Disabilities, the Department of Aging on those level of care rules that the Ohio Department of Medicaid owns. So those are the nursing facility level of care rules that dictate not only enrollment to Ohio Home Care as an example, but also our nursing facilities. This is a very known issue and it's kind of top priority at this point for all three departments. I will say if you're running into specific case issues, please send those my way as well as to the departments and we will work on those on a case-by-case basis. But yeah, more to come hopefully in the next couple months.
All right. Well, Jackie, Nyoka, Debbie, thank you for being here. And thanks everybody for the great questions. I'm sorry I didn't answer them all about nursing and staff shortages. We just can only take on so much. But thanks a lot. Hopefully we'll see you.